respected chairperson, distinguished guest, my respected teacher and learned audience, Assalamu alaikum. I am Dr. Sharmin Akhter. I have completed my MD in pediatric hematology and oncology from BSMMU. Then I started job as a specialist and BMT coordinator at the Department of Asghar Ali Hospital. Today, my topics of the presentation is experience of pediatric bone marrow transplant at Asghar Ali Hospital. This is the list of content. Bone marrow transplant is the procedure that replaces diseased bone marrow with healthy bone marrow. And at first, bone marrow transplantation was performed by Robert Good at 1968 at the University of Minnesota in a patient of severe immunodeficiency from his HLA matched sister. In Bangladesh, it was first started at Dhaka Medical College Hospital in 2014, and Asghar Ali Hospital first started autologous bone marrow transplantation in 2019. Now, we already know the types of transplantation, that is autologous and allogenic. In case of autologous transplant, stem cells are collected from the patient at a specific time to treat the disease and then cryopreserved for future use. And then after giving high-dose chemotherapy, reinfusion to the patient. And in case of allogenic transplant, stem cells are collected from a donor and then it reinfused to the patient, and it is 4 types. And according to the source, we can collect stem cell from bone marrow. We can also collect from peripheral blood and umbilical blood. But recent year, most popular is peripheral blood stem cell collection, because in here there is decreased chance of infectious complication, and here engraftment occur earlier than the bone marrow grafting. But in case of pediatric transplant, here bone marrow grafting is the first choice, because here there is a decreased chance of graft versus host disease. This is the HLA typing, and this is the main in case of bone marrow transplantation. This is HLA gene usually located in the short arm of the chromosome 6, and it is responsible for rejection of any foreign body that enter in our body. And this is the HLA complex. In our hospital, we do high resolution HLA typing from mid genome, but low resolution HLA typing was done in BSMMU. In case of donor selection, young and male donor are usually preferable, and full match donor are highly preferable. Now the step of transplantation. Initially, first step of transplantation is stem cell mobilization by GCSF. Then we collect the stem cell by apheresis or by marrow harvesting, and then we process the stem cell and then cryopreserve, and after that we give the patient chemotherapy according to their disease. Some patient got RIC regimen, some patient myeloablative regimen, and after conditioning we reinfuse the stem cell to the patient. And this is the step of autologous transplantation. At first we collect the stem cell, then process it and cryopreserve it and freeze it in a freezer which have minus 98 degree Fahrenheit, and then we give chemotherapy to the patient, and after that we reinfuse the stem cell to the patient. And this is the process of allogenic stem cell transplant, from where we at first collect the stem cell from the patient, then processing, and then we give the patient high dose chemotherapy and reinfuse the cryopreserve to the patient. But in in our hospital, as cryopreservation technique is highly costly, and that's why most of the time we reinfuse the fresh stem cell to the patient. Now the BNT activities in our hospital, from we have already done total 12 pediatric transplant in our hospital, from which 10 are allogenic and 2 are autologous, and from which 4 patients are haplo identical and 6 patients are full match. And total number of patients is 12, from which 59% are aplastic anemia, 9% DLBCL, 8% AML, APML 8%, PRC 8%, and thalassemia 8%. This is the demographic variable. Most of the patients are actually male, and in case of autologous transplant, engraftment usually occur in day 18 to day 8 to 14, and in case of allogenic, 10 to 18 day. And in our case, one allogenic patient have graft rejection occur, but in case of relapse, no patient develop relapse. And the complication that occurred in our patient in case of allogenic transplant, most common complication is sepsis and acute and chronic GVHD and engraftment syndrome. We also found some patients who have CMV infection, TTP and Press syndrome. And in case of autologous transplant, common complication is sepsis and engraftment syndrome. From the 12 patients, only 2 patients, that is allogenic, died within last 2 years. And graft failure occurred in 1 patient, that is 8.3%. And no patient of auto transplant experienced relapse till death. And we use conditioning as beam, flu-cy RATG in case of aplastic anemia, and TBF with FATG in case of ALL. Now I want to discuss 3 cases. A 13-year-old boy who was diagnosed as a case of AML, and initially cytogenetics was low risk, and then she was got chemotherapy according to MRC protocol, but patient relapse occur within 1 year of completion of therapy. Then we again did cytogenetics and we found FLT ITD positive. Thereafter, we gave the patient triple therapy, that is azacitidine, venetoclax and sorafenib for 2 cycles. And after remission, we started conditioning by fludarabine, milphalan and thiatepa. And patient for GVHD prophylaxis, we gave them a methotrexate, cyclosporine and post-transplant cyclophosphamide. And now the patient is on remission after 2 years of transplant. And case number 2, Sabia Tabassum, severe E beta thalassemia, transfusion dependent. We fortunately found 10 by 10 matched sibling sister, and we patient got FTTA protocol. Thereafter, patient now the post BMT status, patient is transfusion free for last 2 years with no GVHD. And this is the FTT protocol for thalassemia patient. And now the case number 3, Tanjim, 8 years old, is a diagnosed case of severe aplastic anemia, and he had no full match donor, so haplo-identical bone marrow transplantation was done by bone marrow harvesting. And now the patient is stable with normal blood parameter for last 2 years. For the shortness of time, I skip some slide. Now the facility for BMT at Asgarali Hospital, we have dedicated room for BMT with HEPA filter with positive pressure. We have total 10 room, optiapheresis machine, minus 80-degree deep freezer for stem cell cryopreservation, and biosafety cabinet. But the chimerism analysis and the CD34 and MRD analysis was done by outsourcing. Now the actual challenge is a lack of specialized doctor and specialized center in our country, and lack of specialized healthcare provider, and they need extensive training. I think this is the main challenge, and there is no donor registry in our country. And another problem is limited TBI support in our facilities. This is the BMT unit at Asgarali Hospital. This is the optiapheresis machine, and we collect stem cell, and this is our Dr. Bipasha. He's our he's our stem cell collection doctor from blood transfusion department, and this is the biosafety cabinet for stem cell cryopreservation. This is the cryopreservation technique of stem cell at BMT unit at Asgarali Hospital. And this picture is usually not Asgarali Hospital. This is the stem cell collection from bone marrow harvest from TMC Kolkata, and this is the bone marrow harvesting from NH Bangalore, and this is our hospital, and which was done by Dr. Dilshad Jahan madam and our whole team. And this is the 80-degree freeze for stem cell cryopreservation. This is our team. This is the Prothom Alo news when we first done haplotransplantation of AML child. And this is the stem cell bag. Actually, this bag is not only contain stem cell, it also contain hope, laughter, optimism, courage, and joy. This is our madam, my mentor, Dr. Dilshad Jahan madam. From her, I learned everything actually, because I have no training in BMT. And I also thanks to all the teacher of BSMMU, especially Chaudhary Yaqub Jamal sir, Professor Anwar sir. And at last I want to say, in case of childhood cancer, we always treat for cure. We not treat for palliation, because childhood cancer is curable. Thank you all.